instead of 0.9 milligram per kg body weight. And if the patient does not show clinical improvement, you infuse 0.3 milligram per kg body weight intra-arterial on the procedure of angiography, where you see the clot on angiography and you administer the drug. Next slide, please. It has been found that the ultrasound helps in increasing the lytic activity of the TPA. So the transcranial Doppler device can be focused on the MCA whenever you are giving TPA, and the recanalization rates have found to be improved in MCA. Similarly, you can administer ultrasound through a catheter endovascularly also to lyse the clot. Next slide, please. Neuroprotective drugs are very common in the market, like the citicoline, the edaveron, Cognestar, Piracetam, you name it and they are there. They are based on multiple principles, and the idea behind it is to make the brain tissue more resistant to ischemic injury and decrease the functional deficit in the patients. However, none of them are FDA approved, have been found to have statistical results. You are giving them because you expect, hopefully, that some neurons may recover, but you cannot put your money on it that you are putting the drug and the patient will improve. Next slide, please. Single therapy alone may not be enough in a large number of patients with stroke. That is the reason you combine different forms of therapy, like intravenous plus intraarterial, intravenous plus mechanical, intravenous, intraarterial plus mechanical, plus ultrasonic, in order to have better results. Next slide, please. How do you, in a clinical scenario, where you see a patient coming to the casualty, how do you go ahead about these patients? Once you are sitting in the casualty and a patient with acute stroke comes to you, first thing you have to make a diagnosis that this is acute stroke. Second, you have to know the onset of stroke. You perform the NI stroke scale and the Glasgow's coma scale. Now the NI stroke scale is too lengthy. What you can do is you can have xeroxes of it in the casualty in the ICU, and any medical staff can just put marks looking at the deficit, so you have the score. Because you know if the score is more than 4, they become indications for thrombolytic therapy. You secure 2 IV lines, you try to give IV fluids but avoid dextrose. You give O2 by prongs or mass. You send these patients for a brain CT. You send blood tests. I have a list of blood tests here. You can send all routine blood tests in the form of glucose, electrolytes, creat, CBC, platelets, INR, PTT, pregnancy. But the most important test in this is the blood glucose level, which you can do with a pinprick in casualty before you administer the TPA therapy. You have these proformas made, or they are there. I mean, anybody can give you these proformas for inclusion and exclusion criteria, which can be marked in casualty. And if you feel that the patient is an indication depending on these criteria or fitting into this criteria for acute stroke therapy, you discuss it out with the patient, you take a consent, and then you start treatment. Other factors which you have to be careful before you administer TPA therapy is that you should have a blood pressure less than 185/104. Patient with higher BP have higher risk of reperfusion hemorrhage. You correct hyperglycemia and hypoglycemia. High sugars damages the brain, so you should not have. You have to administer insulin to keep the blood sugar levels still normal. Your platelets should be more than 1 lakh in order to administer the TPA therapy. If there are other investigations which you require, other than the fact that the patient is, if they are relevant, like the patient is on warfarin and has shown a stroke, then you definitely have to wait for INR level. Otherwise, do not delay therapy waiting for the routine investigations. If you have to put tubes in these patients like Foley's, RT, and if you feel they can wait for a few hours, please wait, because the patient, if you have minor endothelial or epithelial injuries, these patients will bleed from those sites on TPA therapy. The only tube which you should put in these patients, if you feel is the patient requires an intubation and a ventilator support. If you have to secure an airway, do secure an airway in these patients before you administer. Other investigations, if they can wait for 6 hours and then put the tubes, the rise tube and the Foley's, etc. Next slide, please. As we discussed, intravenous therapy is the therapy of choice for first 4.5 hours. For the last 1 year, the window period is increased from 3 to 4.5 hours in order to increase the number of patients which can benefit from this therapy. We also said that it comes in the form of powder and distilled water. It's got a corkscrew in it where you can just mix it. You should not agitate it when you are mixing it. You just put it on the table and just shake it gently so there are no bubbles. And then you give it the bolus dose as 10% as bolus and rest as infusion over 1 hour. You should remember that the dose is 0.9 milligram per kg body weight and the maximum dose should not exceed 90 milligram. And as we discussed in combined therapy, IV plus IA, you decrease the IV dose to 0.6 milligram per kg body weight and rest as you give intra-arterial. Next slide, please. If the patient is coming late to you or patient has got a large vessel occlusion, and if you have an interventional cath lab with you, then you can administer TPA, urokinase or use mechanical devices. But however, you should have one non-invasive imaging of the neurovascular tree, either in the form of CTA or MRI, before you administer these therapies. This is just, we will see a patient. Whether you can make out, there is on the right side, there is an M1 occlusion. These are the perfusion scans below. There is some effacement on the right side. Next slide, please. This will be very difficult to understand. This is an angiography of the patient. On the left carotid, you see that there is a large bare area. There are no vessels on the left MCA territory because the left M1 is occluded. This is how a major stroke on angiography looks like. This is actually happening inside the patient brain when the patient of acute stroke is coming to you and you are seeing them clinically. This is a microcatheter which is put into the left MCA and you see a filling defect on the right side, which is actually the clot, which is occluding the middle cerebral artery. Next slide, please. And this is after, the up slides are actually after recanalization, when you have opened this artery with TPA intra-arterial, and once you administer these therapies, in 50% of the cases, you will be able to open these arteries and the blood flow will again start to the same territory. So on the right, you see there is no blood on the right MCA. On the left, which is the post-treatment picture, you see there is blood in the MCA flowing into the MCA territory. And the patient, we all know, like the coronary revascularization, the cerebrovascular revascularization helps a lot in recovery of the patients. Next slide, please. This is a patient with basilar occlusion. Again, you see a vertebral artery which is going up and you don't see any flow in the posterior fossa. It's a bare area of the brain where there is no blood circulation. And this is after recanalization, where you can see the posterior cerebral, the superior cerebral, the pica, the contralateral vertebral artery. And you can see the whole basilar being patent and the blood flow being started to the patient's brain tissue, helping the patient to recover. Next slide, please. This is just a stent in place. If you can make out, there is a stent there in order to open because there was an underlying stenosis in the basilar artery. Next slide, please. We'll have a word about the mechanical devices also. This first is the microcatheter which we talked about, which can give you ultrasonic waves in the clot. Second is a concentric device, and this is the first mechanical device which was available to us. And you see there are multiple corkscrews in it. So you get into the artery from the femoral groin. As you do coronary angiography of the heart, you do angiography of the brain. You put this catheter there, you entangle the clot in it, and you pull the clot out slowly from the artery, opening the artery. Next slide, please. This is another picture of how the angiography looks like. If this is a patient with right M1 occlusion, you see on the left side there is no flow. There are no arteries in one area. And if you see later, once you move the penumbra device and you have opened the artery, in the last picture or the third picture, you can see most of the arteries which are patent. Next slide, please. There will be certain situations where you will realize that the patient does not fit the criteria of NIH stroke scale of more than 4, but they are very important. If I'm a patient and my right hand is not working, I am monoplegic. Although I may not fulfill some criteria, but yes, I'm in a situation where it is a very grave deficit to me and I need treatment. Similarly, if the patient gets visual loss in one eye or patient is unable to speak, these are the patients which may be administered intravenous thrombolytic therapy whenever indicated. Next slide, please. Once you have administered the TPA, all these patients should go into the ICU for further management. Then here you have to have a continuous cardiac monitoring, and you should see the oxygen monitoring. It should be more than 95%. IV fluid should be normal saline, and the rate may be approximately 50 to 60 cc per hour. You should have an NIH stroke scale and a BP check every half an hour to 1 hour for the next 24 hours. Next slide, please. As we discussed before, you have to have a very strict control on the blood pressure, whether you need intravenous NTG or labetalol to control it. You need to control sugars strictly. You have to have a patient controlling fever if you need antibiotics and paracetamol. And every patient should undergo a CT brain either within the first 24 hours, either post-treatment. If you think, okay, the patient is not improving or has deteriorated, or routinely as a protocol in all patients the next morning or in 24 hours. No antiplatelets and heparin is given in the first 24 hours to the patient who is administered intravenous TPA therapy. It has been found to increase the rate of hemorrhage. Next slide, please. Once you are in the ICU and you are administering the IV TPA, you should watch this patient is getting any headaches, vomiting, there is rise in the blood pressure, there is drowsiness, there is worsening of the neurological status. If any of these things are happening, you have to discontinue the infusion and order an urgent brain CT for these patients. If on the TPA, the only complication you can have is a reperfusion hemorrhage. If you see there is any hemorrhagic transformation of infarct, you discontinue the TPA infusion, you give platelets to the patient, and you give FFP to the patient. If there is a big clot, you call your neurosurgeon for clot evacuation. Next slide, please. If the patient has got features of raised intracranial pressure, you can use mannitol in the dose of 0.25 to 1 gram per kg. Maximum for 5 days, because after that it starts having a rebound effect. You should taper and take it down. You may use hypertonic saline 3%, seeing that the sodium does not go beyond 155. You may electively ventilate these patients, especially if they are waiting for neurosurgery, and you can maintain the PCO2 to 25 to 30 because in itself it reduces the intracranial pressure. Hypothermia, normally we don't practice, so I will not talk about it. You call a neurosurgeon if you feel there is a large clot and it's causing a mass effect and the patient is going down in neurological situation. Take a neurosurgical opinion regarding evacuation. Next slide, please. Other complications which you may see in any stroke patient is the convulsions. So you use anti-epileptic drugs. Aspiration pneumonia is very common. It is the most common cause of death in stroke patients in the second week of death. In the first week, it is the stroke itself which causes the death of the patient. In the second week of stroke patient, the most common cause of death is aspiration pneumonia. You have to be careful with the feeding parameters. You have to see that the patient has got a head eye and is fed and is burped after the feeds. The commonest causes are dysphagia, facial palsy, altered sensorium, and in brainstem strokes. All these patients have a very high chance of aspirating. If the patient is on mechanical ventilation, VAP is not uncommon in our population. And since these patients are bedridden, you have hypostasis and atelectasis leading to pneumonia. Next slide, please. Other complications which you may see in these patients is the urinary tract infection because of the indwelling catheters. Constipation, you have to be careful because the patients will not be able to tell you. You should start nutrition in all these patients by 48 to 72 hours. Do not keep them nil by mouth for long periods. Either you have a nasogastric tube or a feeding Arine's tube in order to start the feeding. If the patient is unable to take orally for 4 weeks, for more than 6 weeks or more, then these become indication for PEG. You have to call a gastrosurgeon or a gastroenterologist in order to put a PEG tube for feeding. If the patient is on tube and you are trying oral feed, then first thing you do is you take 30 ml of water in a glass and ask the patient to sip gradually. During sipping water and after sipping water, the two things you should notice that the patient does not cough on taking orally and the patient does not have any change in the voice after taking liquids orally. If both these factors are fulfilled, then you may restart oral feeding in these patients. But if you feel that the patient is coughing on taking orally, discontinue oral feed and wait for a few more days, get your speech therapist involved and then retry oral solutions. Next slide, please. Other commonly seen problems in these patients is the deep venous thrombosis and pulmonary embolism account for 10% of deaths in stroke patients, and incidence in the hemiplegic limb is as high as 50%. Early mobilization is a must. The earlier you can take them out of the bed with their legs hanging down or put them into the chair, it's better for you and it's better for the patient. If the patient is non-ambulatory for 24 hours or more, then you put the TED stockings or you start giving them heparin 5000 pt or low molecular weight heparin OD for DVT prophylaxis till they are in the bed, or you can use the pneumatic compression devices. Next slide, please. We will have a word of transient ischemic attack or mini strokes. By definition, they mean that there's a neurological deficit which is lasting less than 24 hours. Commonly, they last for 15 to 20 minutes. Normally, if you with extensive and high resolution imaging, the diffusion weighted imaging are usually positive for stroke. Treatment is actually to prevent larger strokes. Next slide, please. Because they are warning signals for us that more bigger strokes can occur. It has been noticed that 25 to 30% of strokes are preceded by TIAs. There is a 10% chance of having a stroke in the next 90 days, and the maximum risk, which is as high as 50% in these patients, is next 2 days. So if you get a patient with TIA, although he is sitting in your OPD and looking very good and normal to you, the idea is that the workup and the care given to him should be as equal as to a stroke patient, because this is a patient who can throw another stroke anytime. The higher risk patients of having a stroke with a previous TIA is the age of the patient is more than 60 years, the patient is a diabetic, and the TIA was longer than 10 minutes. Next slide, please. All these patients should undergo an echocardiography, should undergo a Doppler for carotid and vertebral arteries, or an MRA or CTA for the neck and cerebral arteries. Do a diabetes mellitus workup, the lipid profile in all these patients. And if their patients are young stroke, then you need a complete thrombophilia workup for these patients. Next slide, please. The first line therapy in all patients, whether they are given acute therapy, then after 24 hours, or if they are not, they should be started on antiplatelets. Any one of the drug you can use. They are all three FDA approved. Either you can use aspirin, you can use clopidogrel, or you can use an aspirin diparacetamol combination. And then you use a single drug for lifelong. All these patients should have an add-on statins in order to have. It has been found that they decrease the risk of recurrent stroke. In some cases, you may require to treat the etiology. Next slide, please. In aspirin, you give a single dose of Dispril, which is available as 325 mg as loading, and then you give 150 milligram OD for lifelong. If you are giving an acute stroke therapy with intravenous thrombolysis, then you start this therapy after 24 hours, and it decreases the risk of recurrent stroke by 22% annually. Next slide, please. Clopidogrel, you give 75 milligram, 4 tablets loading, and then once daily. Studies say it is slightly superior to aspirin. And the third drug which is available to us is aspirin diparacetamol combination, and this is also we have been found in studies that it is superior to aspirin, and it decreases the annual risk of recurrence by 36%. Next slide, please. Heparin has not been found to be the first line therapy in acute stroke, especially of neurogenic regime. However, they have a very high importance in cardioembolic stroke or thrombotic strokes, like the young strokes where there is the thrombophilia workup is deranged. In cases where you have a partial recanalization, you may start them with heparin for a few days. And sometimes if the antiplatelets fail, you can add on an additional blood thinner with heparin in order to prevent the progression of the stroke. Next slide, please. If the patient has got carotid stenosis, which is more than 70%, medical therapy alone is not enough. So these are the patients where you may require to do a carotid stenting. Next slide, please. This is a slide where on the left side you see a severe carotid stenosis, and on the right side this is a patient who has undergone a stent for it in order to open the artery, because the risk of the stroke with this kind of stenosis is still very high. So you have to open the artery and prevent the recurrence of stroke. Next slide, please. This is how the stent looks like on the bare picture. On the bony pictures on the left side you can see the stent. Next slide. Next slide. Intracranial atherosclerosis, we know, is very common in Indian population. Medical therapy has been found to be very of great help. You give double antiplatelets for 3 months along with statins, followed by single antiplatelet and statin for lifelong. However, next slide please, if the patient is having recurrent symptoms, then you may do angiographies in these patients and you may see this is a patient where there is a right M1 stenosis. Next slide please. And this is a patient where this is undergone a stent because he was having recurrent minor attacks in the right MCA territory despite being on double antiplatelets and statins. Next slide please. The causes of cardioembolic stroke you know is ischemic heart disease, atrial fibrillation, filled foramen vein, aortic arch atherosclerosis, prosthetic valves, infective endocarditis. Rheumatic heart disease is very common in Indian population. All this can an embolic stroke in the brain, and all these are indications for long-term anticoagulation. Next slide, please. Atrial fibrillation, the risk of stroke is around 12%. The treatment of choice is anticoagulation. You have multiple scores, the CAD-2 score, the CAD-VAS score, the Has-Bled score. Now, I don't have those scores here, but if you calculate them, you will find if the score is more than the CAD-VAS score is more than 2 and the Has-Bled shows that the bleeding risk is low, then these patients are to be put on oral anticoagulation for life. What we are trying to say here is atrial fibrillation in stroke, the drug of choice is warfarin. The drug of choice is not aspirin. Next slide, please. Aggressively control all the risk factors, that means hypertension. The drugs of choice are ACE inhibitors and the thiazide diuretics. Next slide. Diabetics, you have to control a glycosylated hemoglobin of less than 7, and they have, I think everybody there will know the best way to control it. Next slide, please. The lipids, you have to have an LDL of less than 100, the triglycerides of less than 150, the cholesterol of 100 less than 200, and non-HDL less than 130 in patients who have suffered a stroke. So the lipid profile should be very strictly controlled. Statins are very important in lowering the lipids levels. Next slide, please. On discharge, you tell these patients to quit smoking, stop smoking and tobacco, stop alcohol, exercise daily, and reduce weight. Next slide, please. All these patients will require some form of rehabilitation, so you need a very dedicated physiotherapy center with yourself in the form of PT, OT, and speech therapy, because you know that the maximum improvement occurs in the first 6 to 8 months, and this is the time you have to focus a lot that the patient improves. The rehabilitation should be task specific, it should be repetitive, and the patient has to be really motivated in order to improve, because they are very depressed. If they are young patients, they are very depressed with the disability which they suffer. Next slide, please. We will have a word about venous strokes. Now, the venous strokes comes in clinical presentation. They will come with headaches and focal deficit. They will come with convulsions, altered sensorium, and features of raised intracranial pressure. Now, whenever the patient comes on admission and is unconscious or is deteriorating in the level of consciousness on heparin therapy, the prognosis is not good. Next slide, please. As I said, you need a very high level of suspicion in order to pick up venous strokes. You may do a CT-CT venogram or an MRI-MR venogram in order to pick up the diagnosis of stroke, because here you will see there is a venous thrombosis. Next slide, please. If the patient is in a mild clinical grade, that means the patient is conscious and has come to you with headache and fever and convulsion, the drug of choice is heparin followed by oral anticoagulation for 6 months. But if the patient comes to you in a severe clinical grade or the patient is deteriorating on heparin, then that means the patient is deeply unconscious and heparin is not working. You have waited for 24 hours. There are new deficits occurring clinically, or new deficits, new venous infarcts are occurring on the CT scan. These patients should be taken into the cath lab and local thrombolytic therapy may be administered to them in order to recanalize the sinus. Next slide, please. This is just these are pictures to show. If you can see on the left side, there is an empty delta sign, which is suggestive of superior sagittal sinus thrombosis. There is a hypodensity on the parietal convexity, which is because of the chronic subdural hematoma. On the right side is the DSA picture, where you don't see anything on the top. If you remember your Gray's anatomy, this is a lateral picture for the sinuses. The deep venous system, the straight sinus is patent. The superior sagittal sinus, the cortical veins are not opacified. So on the CT scan, you see suspect a superior sagittal sinus thrombosis. On the DSA gap picture, you see on the angiography that the superior sagittal sinus is thrombosed. Next slide, please. And this is how you do it. You put your wires for clot maceration and you put your microcatheters into the superior sagittal sinus. This is the lower down on the left is the pre-picture where you don't see the sinus on the top. And on the right is the post picture where the superior sagittal sinus has completely opened. And this is how you recanalize the sinus by local thrombosis. I think that is for today. So what do you do? Today we learn that ischemic stroke is an acute medical emergency. In our setups, the drug of choice is TPA in the first 4.5 hours once the inclusion criteria are fulfilled, and endovascular therapy is reserved for large vessel occlusion. Thank you very much.